fistula causes comes here and forms the perineal abscess. This space is very small. So even a small quantity of pus, say 1 cc, 2 cc, patient has such excruciating pain, and when you take an incision, you see only 1 or just 2 or 3 cc of pus, and you wonder why patient is getting so much pain. Because there's no much place for this pus to expand, so they present very early. A low ischioanal abscess also presents early because it is superficial. But a deep abscess here, a ischiorectal or the infralevator abscess here, they present very late. So, as he said, anogenital sepsis, that's what he said, right? Anorectal sepsis. Now, anybody who has an abscess, obviously the pus has not formed here. Pus has come through this, crossed the sphincter, whether it is in the intersphincteric space or in the transsphincteric space. It has crossed or it has originated in the intersphincteric space and then come there. So when we tell a patient, oh, this is an abscess, we are going to drain it, and later on say, oh, later on it has become fistula. It has not later on become fistula. Fistula is already existing. So every abscess, when you get, that means that already the fistula is there. The only question remains whether you should just drain the abscess or we should do a fistula surgery along with that also. So if you know how the fistula spreads, then it becomes easier for us to know what type of, if you know the abscess where it is, we know what type of fistula is going to be there. So very simplicity, very simplistic diagram. So if you have a supralevator abscess, you know that this is going to be a high intersphincteric fistula. If it's a deep abscess, ischiorectal or infralevator, you know this is going to be a high transsphincteric fistula. If it's an abscess somewhere here, you know this is going to be a low transsphincteric. If it's very near the anal verge, you know this is going to be a low intersphincteric. So just by knowing the position of the abscess, we can know what type of fistula this is going to be. Of course, you can do an MRI to further your diagnosis, to know where the internal opening is likely to be located. Internal opening usually is located in the midline, either anterior or posterior. Most of them is posterior. But it will give a good idea. Also, when you get an abscess, nowadays with medical legal awareness, it is better to do an MRI and document that this patient has got an abscess. They will say this is fistula. Sit down with the patient, discuss with the patient. Okay, you have an abscess. I'll try to do the abscess. I will try to do the fistula in the same sitting. Of course, I will drain the abscess. I will try to do the fistula. If possible, I'll do it. If it's possible, it's difficult to do it, or I cannot do it, or I cannot make out where the opening is or where the tract is during surgery, I will just drain the abscess and maybe I will do fistula in a second sitting. If you inform this to the patient is more likely to come back to you when the patient needs surgery for a fistula, a second surgery for the fistula. If you are experienced enough, if you know your anatomy, you know how it spreads, you have done an MRI, you have mapped out the tract beforehand, then maybe you can do both in the same sitting. Can we have this serving later on? We're having a lecture right now. Okay. Anybody from Abbott is there? Yeah. So if you know all these things beforehand, patients who come to me after an abscess, they are referred to me for a fistula. What happens is that the patient asks me that if the previous surgeon had done an MRI, he would have known where the fistula is and he would have operated and I would not need another surgery. Nowadays, patients think like this. So we also have to adapt ourselves. We have to be medical legal very sound. I always tell in my lectures, and many of you must have heard this, that we as surgeons need to protect our ass first and then the patient's ass. Okay? So we need to don't think that a patient will spend so much money for an MRI. Patient is not going to thank you for that. Patient will file a case and tell you that why you didn't do an MRI. You cannot say, I was trying to save your money. Patient said, you never asked me. I don't want to save my money. I wanted to save one other surgery. So don't think about, maybe there are some charitable places you can do an MRI, but document it. It's very important medical legally. If you're sure about say you have a small perianal abscess here, and you have a low intersphincteric fistula, you're sure this is the only thing, you go ahead and do it. You don't do an MRI. But especially nowadays, with the type of patients that we see, it is better to document everything, whatever you are doing. So that was the, now as he rightly said about the anorectal ring is very important, which is formed by the deep part of the external sphincter, the puborectalis or the levator inner muscle here, and the corresponding part of the internal sphincter. All three together form the anorectal ring, and which is the number one thing you should protect. You should never ever divide the anorectal ring. So when you are starting the surgery, what you do is palpate the anorectal ring. Okay? You can see I'm hooking the anorectal ring posteriorly. Just palpate it. Palpate it at the beginning of the surgery. Continue to palpate it during the surgery, especially if you are doing a sphincter cutting surgery. Keep on palpating it during the surgery. At any time you think that this is now becoming thin, you stop the cutting there. That means now if you cut more, that anorectal ring will get destroyed. That's a very practical, maybe not a very, accurate, but very practical way of judging the anorectal ring and making sure you're not dividing the anorectal ring. I do that. Whenever I'm cutting, when I think that I'm cutting a lot of muscle, I keep on palpating, seeing how the anorectal ring is. If I feel that it is getting thin, then I stop there. Okay? And if you have by chance cut it, you should primarily suture it. If you can't feel the anorectal ring is at some point, then you identify the muscles which you have cut and join them back together with a PDS suture. So that was my practical number 3. Practical number 4, this MRI I've already talked about. It is the investigation of choice. Now at places, I understand at small towns or something, it may not be available. But at least on paper you write, advise MRI. If there is not available, patient is not done, but you have advised the MRI. It is not necessary to do MRI in every patient. If MRI is basically a very practical way, of course there is a lot of definition when you should do an MRI or not, but very practical way, practical guide to when you should do an MRI is when you are not sure, one, whether fistula is there or not. Secondly, you don't know how the fistula is going, whether it is going transsphincteric, it's going up, whether there's any abscess. You're not sure, you cannot map out the tract on a clinical examination. If you have a recurrent fistula, because recurrent fistula, patients are very agitated, very disturbed, and it is to be, as I said, to protect yourself, we do an MRI, know, and also for your surgery subsequently we require, you should know what was missed out in the earlier surgery. So you do the MRI and then you know that, oh, this tract is still there. And if you have a previous MRI to compare with, you will know what has gone wrong in the previous surgery, why the recurrence has taken place. So any complex fistula which you are not sure, you should do an MRI. My indication for doing MRI most of the time is I'm not sure whether fistula is there or not. Very early fistulas, or just I've picked up n number of intersphincteric, posterior intersphincteric fistula especially, where they were treated as fissure, there was nothing else. And on MRI, I've got a radiologist who I work with and always do a contrast enhanced MRI, because that is where they will pick up the enhancement. So a contrast, with contrast you should do it. And we have picked up intersphincteric tract, just a few millimeters, just in the intersphincteric space, a small, say, few millimeters in the intersphincteric. That is a starting point we have picked up there, and I've operated and prevented a full-fledged fistula from developing. Of course, you need to have a good clinical acumen, and that is a practical tip number 5. You need, nothing can replace a good clinical examination. So you need to first examine, form your own diagnosis, then do the MRI, sit with your radiologist and compare. I see patients from all over the country coming with MRIs. Almost 15% of the MRIs I see are not very accurate. They do not correspond accurately to the operative findings. So I don't always 100% rely that MRI, if it's done, that's gospel truth. No. MRIs also can be wrong. You should know that. And some of the MRIs are so confusingly reported that even a small fistula can be reported so confusing that many patients are referred to me for surgery. I said, this is a small fistula, but that MRI was so complex that's why the patient was referred to me, although the fistula was not complex. So you have to be, you have to use your clinical acumen also along with that. As he said that you have sphincter saving and sphincter cutting. If you're cutting the sphincter, the success rates are going to be very high, but the chances of incontinence will also be high. If you don't cut the sphincter, your success rate will be low, but your continence will be very high. So incontinence also will be low. So that you have to maintain a balance. Anybody who achieves a balance between these two, sphincter cutting and sphincter saving, is a good fistula surgeon. The next practical tip number 6, and this is very important nowadays because of the laser, I'm telling this, that if it's a low fistula, as Samrat said, if it's going below the dentate line, there is no other treatment other than cutting the sphincter and removing that tract. You have to make sure that there's no other previous surgery done where the upper sphincters are not damaged, whether obstetric injury or something else or something. But if it's a fresh case, there's no sphincter is not compromised. If it's a low fistula, don't do anything fancy. Don't do a laser or a waft or lift. Nothing is needed. You just need to put in a probe, lay open, curate it, and send for histopath. The next tip is to send for histopath. Everything you remove, you should send for histopath. It's very important. Because I know of a case where a patient has filed a case because his tissue was not sent for histopath. After 1 year, he developed a pulmonary tuberculosis, and he said even that was tuberculosis, and that should have been sent. And because his healing got delayed and all that, of course, there was no proof that that was tuberculosis, but he filed a case. So everything you remove from the body, you should send it for histology. That's a must. So low fistulas, you don't need to do anything fancy. Either you can excise it, or you can lay it open. I have seen, in fact, after laser, you talked about laser. After laser, I also talk a little bit about laser. My practice, my work has actually increased after laser. Not because I'm using laser, I don't use laser. But a small fistula like this, which is a posterior intersphincteric, laser was done, and there's not one. Many cases I've seen. The pre-op MRI shows a small intersphincteric fistula. The laser was fired. The sepsis sort of, most of the surgeons who do this without training. You know, we have a lot of Ayurvedic doctors now. As he rightly said, now the lasers are sold more to not allopathic doctors, but non-allopathic doctors. So because you have the laser machine, you have to use it. So the laser was fired, the sepsis spread. Now the patient has referred with a high intersphincteric fistula or a transsphincteric fistula, which was not there earlier. I've seen sepsis going, in one case, in 15 days, the sepsis spread in a female patient with a small intersphincteric fistula, literally maybe a centimeter or so. The sepsis spread in 15 days to anteriorly to the vagina and posteriorly to the sacrum. And the surgeon who operated referred me this patient, and we had to do a debridement and remove the tract. And it became really a complex issue. So this practical tip is very important. If you have a small fistula, just lay it open. Don't do anything else. Excise it, send it for histology. Only if it's a high fistula, then we have this problem about what to do. So as I said, you have two types, broadly, the high transsphincteric and the high intersphincteric. Now, as he said, the high intersphincteric going between the two and going up here, up, as he showed, and the transsphincteric, high transsphincteric travels between the deep part and the superficial part, okay? That means technically it is below the anorectal ring. It is not crossing the anorectal ring, but just short of the anorectal ring. If you were to lay this open completely, you can get some minor incontinence. You will not get gross incontinence because the anorectal ring is intact. Now, anorectal ring also thickness varies from person to person. It is not like a standard thickness in every patient. And when we say divide 1/3, we can't say, we don't know what is 1/3. And practically during surgery, we can't make out. Especially if everything is bleeding, we can't make out. So in high fistulas, if it's a transsphincteric fistula, you have the various sphincter saving procedures. I think the most popular one and the most effective one is lift, because I still feel lift, among all the sphincter saving procedures, their success is measured with lift rather. So the success rate of lift is something which none of these are able to, or at the most they can achieve the same success rate as a lift. And now we are using combination of procedures. Stem cell is something which is something to look forward to, but I don't know how much in the future or how much improvement there will be. So few systematic reviews I will just go through where each procedure stands. Lift, as described by Arun, showed initially when he published it in a Thai journal, he had more than 90% success rate, but that did not translate. So many systematic reviews published after that showed a success rate between 70 to 75%. So if you're doing lift, you have to inform the patient there is going to be a 70 to 75% success rate. You can increase the success rate as you become more experienced. The success rate can improve. And as with all sphincter saving procedures, the incontinence is very low. Limitations: if there's extensive scarring around the anus, then you may not be able to identify that tract. If you don't know where the internal opening is, you don't know where to place your incision. If there is no external opening, you need to create one. Those are not relative contraindication, but they may be difficult. High intersphincteric fistulas to do a lift procedure is difficult because in a high intersphincteric here, they're going up here. So you can go through the intersphincteric space, but you cannot close it. It's difficult to ligate the tract in a high intersphincteric. Those are technical problems. The waft which is there, initially this Transstar was used to staple off the internal opening, but again this is a rigid scope. It's not a curved scope, so to pass it through curved tracks is not possible. And Parkaj did a systematic review of the waft, and he says that the success rate is around 76%. But I asked him how many were in that series, how many were simple fistula and how many were complex. So that was not mentioned. He said that there is no data on that. There's no separation behind simple and complex. So what happens is most of the cases where waft was done, they used to choose simple case to do waft, and complicated cases they were not doing with multiple tracks, branches and all. They were not doing waft. So we cannot actually assess because you cannot compare apples and oranges. If you have to compare procedures, they have to be equivalent cases. But 76% initially, but now many people have actually stopped doing waft and using waft for a diagnostic purpose rather than a therapeutic purpose. Another systematic review which showed a better success rate, and they said that the recurrence rate will depend on how you close the internal opening, using either stapler or suturing or advancement flap. And that's how this systematic review, which was published in 2018, and their success rate almost more than 80%. There was this paper which compared to whether adding waft and combining waft and lift together, whether it will improve the success rate. And this paper, of course, a very small series, and they said that it did not improve these. Combining two procedures did not improve the success rate. It was still the same whether you do waft or lift as separate procedures. The laser, coming to the laser, as I said, this is his 5-year experience which was published in 2017, and he said the primary healing was in 64% of the cases. And again, the 117 patients over 25 months. So he concluded as a moderate primary success rate, and a systematic review and meta-analysis which was published in 2020 that the overall success rate was 67%, and when it was redone, it was 69%. So somewhere around 60 to 70% is a success rate with laser. Again, mind you, there's nowhere they have mentioned that how many were complex and how many were simple actually in that. The plug which came with much fanfare way back in 2006 has gone out of repute because the overall success rate for non-Crohn's fistula is only 54%. So the role of plug is probably reserved for Crohn's fistula. It is a good procedure, gives good success rate in Crohn's fistula, which can be used. Almost 85% in the systematic review. Stem cell is something which is still upcoming, and again, right now they have around 60% success rate. So these are some of the sphincter saving procedures for a transsphincteric fistula. What about sphincter cutting? So as I said, if you cut the sphincter, you have a very high success rate. So you can cut the sphincter, either do a fistulotomy, fistulectomy. If you're cutting it there, at that level, it's better to suture it. If you're cutting it low down here, you don't need to suture, as I said. If you're cutting it here, you may not get gross incontinence, but if you suture it, you can improve the continence. Now, cutting sit-on. Cutting sit-on also is a type of a cutting procedure, sphincter cutting procedure, especially the Chha Sutra, which is extensively used in our country. So this systemic review, which is rather old, showed a fecal incontinence rate almost reaching up to 25% in cases where the internal sphincter was divided. But really, I'm not very fond of a cutting sit-on. Firstly, you have a lot of pain. Patients have a lot of pain because when you tighten it, it gets very painful. And secondly, if you have to cut it slowly, because if you cut slowly, it's supposed to cut slowly so the sphincters do not separate far apart. That's the whole rationale behind using a slow cutting sit-on. But I personally believe if you have to cut it, you might as well cut it and suture it. At least the continence would be better than just slowly cutting and causing great pain. Also, if you are using a cutting sit-on, don't use it right. Don't cut it right from the skin onwards. Only the part of the sphincter. Again, you should know how much of the sphincter is involved. What type of fistula this is? Is a low fistula, high fistula? How much sphincter is going to get cut also is important. And never use a cutting sit-on in an anterior fistula in a female patient, because definitely the patient will going to get incontinence. So fistulotomy and fistulectomy success rate is high, but incontinence can go up to as much as 20%, but usually it is minor. So this systematic review, which was published by the Ratto group from Italy, basically most of the cases were his own in that systematic review. And he said the overall success rate was 93%. So this was probably one of the highest success rates of any procedure. And suturing the sphincter, when you suture the sphincter, primarily, not a delayed repair, primarily, your anorectal manometry parameters were unchanged. The quality of life, which is a basic parameter, was improved significantly. And thus, the success rates are very high, and the risk of post-operative fecal incontinence was lower than after a simple fistulotomy. So, one problem that they have, if you cut the sphincter posteriorly and suture it, you can have a keyhole defect. That is one of the drawbacks of this. So what this does is the stools get stuck there posteriorly, and when the patient walks, the patient says that some stools leaked out. So it is not like incontinence. It is just that the stools get, like in a sort of a depression, they get stuck there and then they come out. So the simple thing I ask them is I tell them to wash after passing stools with a hand shower. Then I tell them, go out, just walk for 5 minutes. Again, you go back and wash. So whatever stools are stuck there, they get washed out. So when they walk, that's when the stools slightly extrude, and then second day when they wash, they can get clean. So that post-defecation soiling, as it is called. So that was a main drawback, complication in this procedure. So I'll show you this one video. I think some of them must have seen earlier. This was a young girl. You can see the sit-ons were passed. She was operated 4 times. She had everything, right from lift to laser to everything. She had a bilateral transsphincteric, high transsphincteric, and a bilateral high intersphincteric extension. So this video will explain all the anatomy and everything very well. That's why I've just kept it. I always inject methylene blue before my surgery. So there was a one tract here. This was posteriorly, and this was laterally. And of course some skin tags and all that. So what I'm doing is I'm going to be doing a fistulectomy here. So you should not do a fistulectomy at 2 places. If you're cutting the sphincter, cut it only at one side, not at 2 sides. So the advantage, so first I'm removing this whole tract by doing a fistulectomy, right, including the anal sort of internal opening, the anal gland complex, everything I'm removing first, okay? The advantage of a fistulectomy over a fistulotomy is you can see everything under vision. If there's a branch or if there is an abscess, you can see that. So if you have missed out a branch or something, the methylene blue will highlight it. And so everything can be done under vision. I'm operating this under local anesthesia. I do under local anesthesia with sedation. This is the internal opening. And this is how you locate the internal opening also. Suppose you have not located the internal opening earlier, you can just give a tug on the tract and you can see where this is getting pulled inside. That will tell you the location of the internal opening. So I'm just, now I know by my previous anatomy and how way it spreads, that this is a high transventric, but it is not crossing the anorectal ring. It is below, I'm going to be below the anorectal ring. Okay. So I'm a little radical in my surgery. Everybody doesn't have to be radical. Whatever I'm doing doesn't mean everybody has to do that. You have to choose your own procedure. But this is what I do. So you can see I've almost come to the internal opening now. Okay. Now this part I'm going up to the intersphincteric space now. Okay. So now I'm taking an incision around this. Now this tract I will excise till the external opening. Okay. I'm not going to cut the till the external sphincter. So this tract I will core out till the external sphincter without cutting the external sphincter here. Okay. Then I will core it out through the external sphincter. Just a small hole in the external sphincter. I will remove this without cutting the external sphincter here. So this is the dissection I'm doing till the external sphincter. So when I come to the external sphincter, I will stop there and go back again here. So that was that part. So only up till here I have dissected this part. I have not cut the sphincter here. Only this part I have dissected. And then I will just core it out through this without cutting this muscle, just core out through this. Okay. And try not to create a big hole in the sphincter. So we just, once you see the tract entering the external sphincter, you narrow down your dissection, or you can just curate that part also. Instead of excising the big chunk, making a big hole in the external sphincter, you can just curate out if you want. Okay. So now I stop there. Now going back to the incision. Now that was the internal opening now. Okay. So I use a cautery. I use, this is local anesthesia with adrenaline. Now this is the branch of the high intersphincteric. This is not going above the levator. This is below the levator. But I'm excising this branch. So I go up to here, remove this branch completely. Okay. So now I'm in the intersphincteric space on this side. That's on the right side, right intersphincteric space. You can see the external sphincter deep part is here. Okay. And this is the internal sphincter here, somewhere here. And I'm doing an intersphincteric dissection now between going, and there was an intersphincteric abscess also here in the midline, which also I will excise along with the specimen. So you can see that dissection now. So just follow the fibrous tract. That's all. The tip is just to follow the tract. Don't go away from the tract. Very close to the tract. You don't want to unnecessarily sacrifice some muscle. Keep as close to the tract as possible. That way you're safer. You're not cutting too much muscle. Now you can see I'm going in the intersphincteric space. Now in the midline also here. So behind whatever you see is the external sphincter. The deep part of the external sphincter is behind this muscle. Now going on the other side. Similarly on the other side also I will core out and remove. And then do a dissection, and whatever little part of the tract from inside I can remove, I will remove this. And then disconnect here and disconnect here. Take this part here in this. So now the intersphincteric dissection on the other side. Now this was a young lady. She was not married, going to get married. I mean, her marriage was delayed because of this actually. So they were very anxious, and they wanted, since she was operated already 4 times before, they were very keen that she should get cured. So you see that is intersphincteric dissection on that side. And you can see the little bit of the branch of that tract, of this tract here. So I will disconnect that tract here. A lot of smoke, so you can't see well, but similar dissection that I was doing. So this is the intersphincteric dissection. You can see now you have normal tissue come here into. So till you see the normal, sphincter, you keep on dissecting. Now this is the tract of this side. You can see that part. So now I have cored out through this. I will disconnect here and remove it along with the specimen. And then this I will remove separately from here. Okay. So this is a very classic case to show you. You can see now I'm disconnecting from here. So that is the transsphincteric tract of the left side. Okay. And now the remaining tract are pulled in here. Okay. So now you see, that is the mucosa there. That is the internal sphincter. That is the external sphincter behind that you see. That is the intersphincteric space on either. There's a horseshoe intersphincteric space, okay, where I have removed that. So the entire disease is removed, and that is a transsphincteric on that side. So then once you make sure that everything is out, there is no disease left behind, you can suture it. So for the beginners, when you want to suture it, when you want to do this procedure, when you're dividing, you take stray sutures on either side of the muscle. So you know which end will go where when you are suturing it. Okay. So for muscle, I use PDS, and for mucosa, I use Vicryl you can use. So here this is the internal and external sphincter, both I'm taking. So the intersphincteric space I'm closing now. You can see that intersphincteric space being closed. And subsequently the muscles you would close as whatever you have cut you will close. You can see that intersphincteric space and that side being closed. You can do this only if you make sure that nothing is left behind. If there's abscess, you have curated it, then you should not close. If there's a space there that you should not close, especially a fibrous sort of abscess wall is there, then it will not close, or there will be a collection subsequently. So just simple sutures. I usually take inverting sutures, so the needle, that suture end sometimes pokes inside. So if you invert it, then it doesn't poke. So just this one video I wanted to show. So that showed a lot of the anatomy, and you can do both transsphincteric and intersphincteric. And this is Arun's grade 6 classification. So grade 6 is what I suggested to him. He didn't have it initially. And I said, no, you should, because there are combinations, so you make a grade 6. So then we made a grade 6 classification, combining both transsphincteric as well as intersphincteric fistula. Okay. So close, because the disease is removed, the anal gland complex, the tracts, everything is removed. So this is a very clean wound. In fact, I don't use antibiotics also. After this surgery, 1 dose of prophylaxis is what I use, because there's no infection, there's nothing infective left, so you don't need antibiotics. Only thing I would use will be a laxative post-op. I use lactulose. Our sponsors are there today, Dufalac sponsors. So I use that actually after surgery. So all my patients go home with 1 laxative and 1 analgesic, that's it. So many of them call me up, especially doctors who I operated, that, oh, you've forgotten to write antibiotics. So they call me up after surgery. And you can see now very nicely the things are coming together. Then the mucosa now with Vicryl. Okay. So if the mucosa breaks down post-op, you don't have to worry about it, because that's not giving strength. That is not responsible for your continence. But suturing the mucosa makes the post-op dressing easy, because then the stools do not collect there and the stools just come out. So it makes the post-op care easier. But if you think the mucosa is coming under tension, don't suture it. Any tissues which are coming under tension, don't suture, because more often than not, they're going to break post-op. So especially if your ends, if you have taken, 2 different ends and try to get them, they will not come together. That's why you should know which end will come where. And the tissues, if you have to suture, then you should excise the tract, do a fistulectomy. If you do a fistulectomy, then all the fibrous tissue is out, then the remaining tissues are very soft and supple, and you can suture them. I do this procedure even after an abscess. If an abscess is there, I normally, with small abscess, I excise the abscess with the tract, and remaining tissues become very soft then. Okay. You can see. This is sort of a longer version of my video. I should have gotten a smaller one, but I just wanted to show all the steps, so that a lot of questions which people ask, I'm trying to answer by this. So one of the drawbacks of suturing is pain, post-op pain. Okay. So I inject methylene blue, 1 cc of methylene blue and 5 cc of bupivacaine 0.25 or 0.5 that is 6 cc, inject into the mucosa, inject into the muscle, whichever is suturing, because the pain is the mucosal pain, especially the anoderm when you suture, it gets painful, and the sphincters when you suture, it is painful. So there I would inject into the sphincters, I would inject into the mucosa, whichever area I have, where I think patient is likely to get pain. Now this hole, as I said, is closed, and I would, I can't fast forward this, so we'll just go to the end of this, just to show you at the end. See this, another layer of suture I'm taking here. So trying to disconnect this completely from there and make it into a flat wound, so this becomes okay. You can see, now even cosmetically, if you see, it's not a very bad looking wound. And this thing, you can see this, I've sutured it, you can see. And if you see the tone also, as you will see, is very good. It's quite tight. Don't make it excessively tight also. And you can see that the very superficial wound is there. After 3 weeks, and I don't have the picture of, she took 3 months to heal up totally. In fact, I should have put that video, photograph of the what happened? The lecture is not over. Okay. 3 months she healed up and there was hardly any scar seen. And the best thing was they called me up that I think after a couple of months she did get married. And they were just waiting for this to heal up before marriage. So that was something good. So another thing is combination therapy, as I said, can be used. You can now combine various things, slightly improve the success rate. But I think lift is one of the mainstay in the treatment. Just one word about the high intersphincteric. Now this is something which is very difficult to diagnose for most surgeons, because most of these patients, they do not have any external findings. You get anal pain and they present with anal pain, pain during defecation, pain after defecation. Especially if I have a history of patients saying, when I pass stools, I don't have pain, but after 5-10 minutes or half an hour, the pain starts. That should alert you that this could be a high intersphincteric fistula. Very typical history. Or patient complaining of anal discharge. I had a patient who was complaining of anal discharge and he went to the medical gastroenterologist. I hope there are no medical gastroenterologists here. He went to the medical gastroenterology department and for anal discharge, and they thought that he's passing stools from there, and they labeled him as fecal incontinence. And with that fecal incontinence, he was referred to a surgeon. They said nothing is there, this, that. Then they did colonoscopy. Everything was done. They couldn't find anything. And finally they said, no, but his tone, manometry was done. Manometry was normal. Then finally he was referred to the psychiatric department and he was started on antidepressants because he's complaining of anal discharge. But he was like, I'm not like, I'm okay. I don't have any other problems. Then he was working for somebody known to me, and then he referred me. So the moment I examined him, I'll just show you this. In this position and strain, you can see this pus coming out. This is very typical of an intersphincteric fistula. So always when in the OPD, when you are seeing a patient, any patient you are seeing, patients may come with a fissure, history of fissure or a history of hemorrhoids or anything. I always ask the patient to strain. And there are some cases where patient had very typical history of hemorrhoids, bleeding, prolapsing mass, but patient had this. And then I know that this is, patient may have associated hemorrhoids, but patient also has this. Every patient normally I put in lateral position and I ask them to strain, you know. So many of them get treated for fissure, but on examination you may not have no external finding. It may be a normal tone, and if you don't see a fissure, patient's getting anal pain. Think about this. And if you do an examination, you may feel induration inside. Everybody should train, especially the youngsters who are here. You should train your finger to first feel the normal. So you do PR on normal people, normal patients coming with hemorrhoids, is that, or even otherwise, even if you have abdominal case, normally you're supposed to do a rectal examination. Get the feel of normal, then you will know what the abnormal is. And of course, if you if all this history is there, then you can do an MRI and pick them up. And this, as you said, what are the options? We need to get rid of this tract. Now, there are various options to do this. One is I showed you, I excise this whole tract and remove and close this intersphincteric wound. That's one option. A simple option is to go through the internal opening. I think Samrat showed in the video, put in a hemostat forceps and lay open this tract like a fistulotomy. So what you're doing is you're dividing the internal sphincter. So either you can go from the intersphincteric space or you can go from the internal opening and open up this. So this becomes like a fistulotomy, it becomes a flat wound. So post-op, you need to keep on flushing that wound and allow it to heal. So like a fistulotomy. Another thing you can go see, the anal gland complex is somewhere in the intersphincteric space. So not only for this patient or for any patient, if you excise the internal opening, go deep till the intersphincteric space and excise whatever induration is there, that means you have taken care of the source. Suppose patient has got an abscess, you have done the abscess. But from the abscess, you cannot make out how the tract is going here. But if you can know where the internal opening is, and even if it's not communicating with the abscess, if you just excise this internal opening, you have decreased the chances of recurrence. So there's a simple procedure like this. So in this case, you can do that. And the upper part, you can curate it. You can put in a laser fiber and burn this, or you can put in a waft scope and burn this, or whatever. But basic thing is you have to destroy all the granulation tissue which is there. You need to curate it, whatever procedure or whatever energy device, or just you can take a cautery tip also and cauterize that. So those are the things. So I think I don't want to take up too much time now. So the high fistulas, as you said, now these patients have to be operated from, if they're going up to the abdominal wall, you need to remove from the abdominal wall. Here, whatever you want to do, as I said, you can do, and this part you need to curate it. These are not so common. I see about 5-6 a year patients like this who infection goes to the abdominal wall. Okay. So the last slide is the tip is initially if there's a high fistula, you can try a sphincter saving procedure. If it doesn't work, you can repeat it again. But discuss with the patient. This is what I'm going to be doing. I tell my patient what I do. I said, this is for my procedure, the published success rates are this in the literature. What is my personal success rate? I tell them this is my personal success rate. And explain to the patient what they should. So I don't promise continence to flatus. I tell them 30% of my patients lose continence to flatus, out of which 50% regain back. But it doesn't affect the quality of your life. Because the simple example I tell my patients, I said, if you are sitting in a meeting, when was the last time that you need to control your gas or hold it? So most patients can't remember when was the last occasion I needed to control my gas and I was in a meeting. Most of them cannot recollect that, even if I ask any of you all. So that doesn't affect the quality of life. But I need to tell my patients that if they do get flatus incontinence, they need to be aware that this is the procedure. I'm going to do a sphincter cutting procedure, so that possibility is there. So if it's a recurrent fistula, then it's better to do a sphincter cutting procedure, because then at least that will give them a permanent cure. So complex fistula has no standard surgical procedure. What I do doesn't mean everybody has to do that. You should do whichever procedure gives a good success rate in your hands, and whatever you have trained at, you should do that procedure. MRI may be very useful before planning the surgery. And very important in today's day is discuss the pros and cons with the patient, sit across and discuss. Tell the patient what to expect, the recurrence, the pain, the incontinence, everything you discuss with them. And of course, best results are with high volume surgeons. So thank you so much.